Welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined by Leigh Burchell. She's the Vice President of Policy and Public Affairs at Altera Digital Health. Thank you so much for being with me today.
Yeah, happy to be here.
So, you have a really interesting role that you do as your job, but then also you volunteer your time as the chair of the Electronic Health Record Association, right?
That is true. That is true. I kind of wear two hats. Altera coming first, of course, and then I help out. The Electronic Health Record Association is our trade association for health IT companies, and it's really pretty much volunteer driven from almost 30 companies across the industry, and we all kind of work together on mostly policy related topics and certification and things like that. So I work in both of those environments.
Now, does that make you a glutton for punishment?
It sometimes can be challenging, but I will say the EHRA work is really helpful to my day job. I learn a tremendous amount from, collaborating with people at other companies, and the power of the trade association frequently means that we're able to meet with people who might not necessarily say, I don't want to work with every single individual health IT company. Let me work with a whole bunch of them together. And so, we get access to and the opportunity to ask questions of and advocate to people collectively that's really beneficial to the company. So ultimately, I'm kind of helping both organizations at the same time, but it absolutely is good for Altera.
Yeah. And then how did you get your start in healthcare?
Well, going back to when I was a baby, no, I'm just kidding. My dad was a doctor and my mom was an OT who specialized in MS and fibromyalgia. So healthcare was just kind of around the dinner table. I grew up, spending time in the hospital when my dad was working, and, certainly don't get any kind of heebie-jeebies when I go to the hospital now, because it's kind of a comfort environment for me, oddly. But I thought for a little while I might be a doctor. When I first headed off to college, I thought that was what I was going to do. But I got involved extracurricularly with some organizations and activities that were more law oriented, constitution and, the mock trial environment, that kind of thing. And I really enjoyed it. I always was kind of writing focused, and that fit in well there. So, that kind of was an interest. But when I first graduated, I actually got into public relations using the writing skills. I was in finance and healthcare for PR, and ended up working for a payer as one of my first jobs. It was Oxford Health Plans, which ended up being subsumed by United. But I was working in PR there, and then started doing work on a preventive care program. And that was my first exposure to kind of the power of thinking of the patient first. And what do we need to do? Oxford was pretty innovative, and they were willing to put money into, this goes back quite a while. I've been in my career for a while, and they were willing to put money into really proactively trying to get people to do their preventive care exams, to have mammograms, to do diabetic retinopathy exams, things like that, to head off worse experiences down the road. And I would get letters from people because I was running this program. I got a letter from a woman who said, I had breast cancer and I had no idea. And, I think this saved my life. So thank you. And I really was like, wow, that's kind of amazing. And then my husband and I moved to North Carolina, and I was looking around. I still wanted to be in healthcare, but I found a company that at the time was called Medic Computer Systems, which has evolved into Altera. And I just loved the idea of the intersection of healthcare, which I was passionate about, but technology, because, technology is where we're going, right? And I knew it was going to change healthcare, and it just really kind of fell together, and it's been a great career.
Yeah. So you've been with them how long?
25 years.
Wow. They haven't scared you off yet. It must be all
No,
right.
no. And, it feels like different companies, right? Because we've been through a lot of mergers and acquisitions and spinoffs, and all of this kind of thing. And so every time you have a new CEO, every time you have new executives, it feels like a different company. So I have been here a while, but I've had a lot of different experiences, a lot of different opportunities, a lot of different roles. And so it's really been a great, very fulfilling career.
It sounds like it.
Yeah.
And you've been able to work recently on some of the requests for information with HHS, right?
Yeah. Yeah, the second Trump administration that we're working with now, they love an RFI. There are a lot of RFIs that have already been out. We're only 6 months in, and there have been a number from CMS, from HHS, from a different form of CMS, from ASTPONC. We provided proactive input with deregulatory ideas to a couple of different environments as well. Um,
Mhm.
I think there's an opportunity right now to remove regulation that isn't really adding value, that is just slowing down innovation, or not really helping the providers, or not really helping patients, while keeping an eye on where do we still need it? Where does the industry still benefit from guardrails or from standards promulgation, things like that? So that's a lot of the input that we have provided, but lots of RFIs.
Well, and I love that the priority is on communication, and you are an expert in communication, kind of serving as a translator between like healthcare, IT, and these regulatory policy government um, players in this. And it sounds like you have such a rich background to pull from and a real understanding of the implications on the human level of these decisions that I would be really concerned about decisions that are made by people who don't understand the implications of them. So thank you for your advocacy to connect those dots when things
Yeah,
might
no,
come
I
up
think
in
you
translation.
summarized it really well. I mean, my job in my specific role, right, government affairs, public affairs, is to bring kind of three different prongs together: healthcare, technology, and policy. And it's advocacy on all of those. Part of what
Mm,
I do is understand health policy, not only regulatory requirements, but the why. Why is CMS thinking of something, or why is Congress taking action here, so that I can then bring that in house. I can help people understand what people are trying to accomplish from a policy perspective, so I can translate that internally. But then externally facing, a really important part of my job is to say to regulators, or to the administration more broadly, here's what your idea would mean in practicality. Here's the amount of work that would have to go into it. Here's where we are missing standards that are needed for my company and the others in the industry to approach this in with some level of uniformity, so that we can all share information really cohesively, right? And it can be beneficial and consumable. So there's that part of it. And then also, what does it mean to our clients? I really frequently take the approach of advocating on behalf of our clients, community hospitals, physician practices, independent practices. What is this going to mean to them? What's it going to do to workflow, or how is the patient going to receive this technology, which has a lot of relevance right now as we talk about AI adoption, as we talk about data segmentation requests from patients, just interesting kind of topics that all play out in different ways. But that, I think, is, you said it, my job is kind of to translate between all of these different people who aren't necessarily thinking of a perspective other than their own, and trying to help them say, oh, let me consider that, so that what we do collectively, we're all working towards the same goal.
yeah.
How can we do it in a way that's user friendly, that isn't burdensome, and that ultimately helps the patient?
Yeah. And I do interact with the EHR daily in my
Mhm.
job as a nurse. When I support families, especially after stroke, a lot of the time they'll have a caregiver who will need to translate for them. Um, they may have aphasia, which is when you can't speak for yourself, even if they're able to think clearly. And so, even using things like my chart can come across barriers in just getting access to that from the family member and them learning how to navigate that system. So, um, for EHR situations that are not really built with the caregiver or proxy access in mind as the priority, how can we fix that? And what would it take for our health data policies to work better for real world caregiving situations?
Yeah, I think what you're talking about is not necessarily a technical problem. The majority of patient portals and personal health records that are out there, I don't know of any that don't have a proxy option.
Right.
An allowance to identify that someone else can have access to my chart and can, communicate for me and all of that kind of thing. And
Yeah,
it's
I think more
frequently go
the
ahead.
I think more the confusion happens with the privacy concerns around HIPAA.
Exactly.
How do we know that we have the authorization to let this person be the proxy access? And
Yeah.
it just seems like unclear. So,
Yeah, I
um,
think there's a couple things that go into that. Number one, particularly you're talking about a pretty traumatic emergency care event. And people aren't expecting that, right? I mean, no matter how much we all say none of us are here forever, and you need to kind of plan, have conversations, people don't necessarily do it. And so I have a healthcare power of attorney. Everybody in my family knows where it is. Everybody in my family, including my children, have healthcare power of attorneys. And, so that I can go in to an environment in which someone is in the ICU or otherwise unable to communicate, and I can say I'm allowed to do this, right? And by that, I can be given proxy access to the EHR or to the portal. But a lot of people don't do that. A lot of people haven't signed the paperwork, and largely those kind of limitations on proxy access or the ability to act on someone's behalf really are about privacy and consent. And,
Mhm.
there's a lot of complications. There's a lot of scenarios in which people might need that, whether it's the elderly, whether it's someone like you're talking about who had some type of unexpected emergency, or even teenagers. There are issues around proxy authorization or prohibition, not allowing parents to have access to a record. So there's a lot of different scenarios, and people don't necessarily think through them. And I mean, I'm always telling people, what do you have signed? What are you doing? Who knows what to do if you are incapacitated? But it really just is about that consent management, less about the any kind of technical limitation.
Right. Yeah, definitely more about this privacy.
Yeah.
Um, Now, on this podcast, I interview a lot of very passionate, innovative people who are trying to build tools that help family caregivers stay organized and feel more in control of their health journey. And from where you sit, what kind of ideas are EHR companies actually excited to support? And what are the kinds of solutions that they're more hesitant about?
So I think hesitation would either come from, it's not hesitation, but it might be frustration, a regulatory mandate that it's kind of unclear what's the benefit of that. None of
Oh,
us have endless resources available, and we want to spend our time on things that our clients are going to find valuable or that are going to offer real value to patients. So where we end up with regulatory mandates, that we have to put things into our products to get certified, and we know our clients are not going to be enthusiastic about using it, that can be frustrating. And so probably a little less enthusiasm there. We are driven, of course, to make our clients happy and to offer solutions and expansion of functionality that is going to help our clients. I mean, we impact the care that patients receive with our software. And it's one of the things that I find gratifying, is that I know for a fact that our technology directly affects, the quality of care that people get. When clinicians have more access to information and it's consumable, it's a way that they can process it. It's not too much. It's not too little, right? It's the Goldilocks scenario
mhm.
that can affect the patient and the outcome and their experience and all of that. That's amazing. And I find that to be pretty meaningful. And so that is, where we have to choose to spend our resources. We want to do it on things that either the providers themselves are going to say, wow, that was helpful. Wow, that saved me time. Wow, that gave me information that I didn't have, right? That might be the opportunity for AI, ultimately, as we, kind of test through and start rolling that out more and more, if AI can tickle a provider and say, hey, have you thought of this? Or it might be this, and that really changes an outcome for a patient, that's fantastic. And then ultimately, we want to help the patients. We're all patients. We are all patients clinically, and we are all patients from the perspective of the same frustrations of trying to move our data somewhere, or access it, or having our parent being able to help them, like that kind of thing. We're all in the same boat. We're all humans. So ultimately that's what we're trying to do.
Yeah, definitely. And I know there's a lot happening with new laws right now, some at the federal level with the new administration's Make Health Tech Great Again
Mhm.
initiative. I don't know when the health tech was great or great before, but I want it to be great. And there's also a lot of individual states that are making laws around things like
Yeah.
privacy and AI. And I imagine that makes it really hard for health systems and EHR vendors to keep things consistent and easy to use. So, from your perspective, how do we keep moving forward in a way that protects people's privacy but doesn't make the technology so complicated that families and clinicians can't use it well?
Yeah, it's a great question. You kind of raised two scenarios that we're tackling right now in health IT. Number one is, what is the Trump administration going to do? And what change will that mean? What will we have to do to be compliant or to support the goals that they're laying out? And they did do this Make Health Tech Great Again event just a week ago from today. So we're in early August. And a lot of that is around rightfully trying to ease the process through which patients can access their full record, not portal by portal, but, really
Right.
having the full picture,
Mhm.
and move it where they want, control who sees it, all of that, which is awesome. But they're also pretty focused on expanding the use of health apps by patients. And some of that is around that, consolidation. Is there an app that can pull all the data from all of the different portals and make it, movable in a single thing? Like that's an app. But also, diabetes management or MS management or whatever,
Mhm.
that part does introduce some privacy and consent, sticky situations, because a lot of those apps are not covered by HIPAA. And so patients are not necessarily aware that when they load their data, they could load their full record in theory, into one of these apps, that's not protected by HIPAA. There aren't the same limitations. And some apps have voluntarily said we will kind of follow the same rules, but they don't have to. And so that's an interesting privacy and consent topic that I think there's going to be a lot of conversation about that. And then secondarily, as you mentioned, there's a lot of activity at the state level around health IT. We kind of knew it was coming. Years ago, it was pretty clear that as health data became ubiquitous, as everything was digitized, health data has tremendous value monetarily. So, kind of chiming in on some of that. There's exposure around some things legally in from state to state that vary, right? So reproductive care is treated differently in neighboring states. So some states are taking action around that. And then also AI, as you mentioned, there is a lot of activity around AI, and who has to be aware that AI is in use, and what does the provider have to do, and what is the provider authorized to do with AI versus not, and all of this kind of thing. So all of that is very much fluid at the moment, but it does make it challenging for us as software developers. We don't want 50 different flavors of our software to be necessary to comply with the state environment, right? We want a stronger federal framework for AI, as an example, that's consistent and that gives us our guardrails and says, go innovate, go do cool things, but let's make sure we're safe and that we're transparent and all of that. That is so much easier than California, Texas, Massachusetts, New York taking all these different approaches. And so that's a challenge. It's definitely something that's taking a fair amount of my time right now.
Right. Or heaven forbid, all 50 states having a different set of guardrails, in which case, like, how do you handle
Yeah.
this slinky? Because
Yeah.
that's what it sounds like to me, is like an EHR slinky, like
Yeah.
your size of what you can accommodate. And
Yeah,
I
that's a good analogy. And I mean, providers don't always, I mean, there are obviously large health systems that operate in multiple states. That's complexity for them as well. I mean,
exactly.
you have a law in California, for example, that reproductive and gender affirming care data cannot leave the state electronically. There's
Oh.
this law that's in place. Well, there are health systems that operate in Nevada and Oregon and California. Those
Mhm.
are all different environments with different laws. And what happens, I mean, it's really the same EHR because they're all logged in, they're all the same health system. So there's like a lot of complexities, some things where standards aren't quite finished being developed through consensus models. And so, we're always trying to say to the policymakers, hey, we need this standards based approach. Let's slow our roll here, let's do it right, all of that. But they're eager to implement their political agenda, whichever one it is. And so it's always a negotiation.
Yeah, definitely. And I think this brings us to our $1 billion question for the session. And you have a very full answer. So I can't wait to get into it. Because I do have everyone premeditate their question beforehand, but you don't have to stick to it. So if you came up with a genius idea in the midst of us brainstorming here, that's fine too. Uh, but if you were given a grant, Leigh, for $1 billion to
Okay.
meet the needs that you to meet the needs that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
Yeah, it was an interesting question when you sent it ahead of time. I really kind of thought about it because I had all these different ideas and thought about it. I think there's two places that I mostly landed on. The first would be um, kind of the health equity SDOH conversation that we've been having for a couple of years, and that's changing a little bit with the current administration. But the idea of health starts at home, and it starts with nutrition, and it starts with access to your best opportunity to be healthy. And I see this some within places where my kids spend time, and they go to a fantastic magnet school, and there's a lot of socioeconomic diversity there. And there are people who really truly they don't have access to fresh fruit, and they don't have places to run around as kids and get exercise and be surrounded by trees and all of that. And I mean, the evidence is so abundantly clear that your zip code determines
Yeah.
your health outcome, right? And so there have been some states that have done some really innovative things and allowed Medicaid to pay for prescriptive, boxes of produce, or to pay for kids to be involved in sports leagues when otherwise they wouldn't, things like that. So that's an area that I'm definitely interested in. I'm passionate about. The other would be I would love to see, and this is such a challenge, it's not for lack of trying, but more research and support for dementia care and Alzheimer's and other dementias.
Mhm.
It's the fastest growing chronic disease in the country because we have an aging population and people are living longer, and more and more and more people are expected to be diagnosed with some form of dementia. And it's not only their experience, but it's also the caregiver experience. My mother passed from dementia, and I know what that experience was like. And people aren't ready for it. This country is not ready for it. We don't have enough memory centers, care center, residential for people with dementia. We don't have really any type of support for caregivers. The mental load, all of that is really terrible, and I just feel like we're unprepared. So I would probably put a fair large chunk of my 1 billion into that. And I know a lot of people are trying to help with that, but, maybe setting up some more care centers where people can take their family members who have that, or, just really trying to help from that perspective is something that I would love to see us do more of, for sure, as a country. So put my money where my mouth is.
I love that. I love that. And the thing is, you're talking about like the whole spectrum of life there, with nutrition, with like walkable green spaces or opportunities for low cost exercise, which is just not safe in some places.
Yep.
And then caring for our elderly, especially. And so I saw there was a book out about bringing back the village,
Mm,
where we have community gardens
uh-huh.
and um, people look out for each other, each other's kids, and then the older people can like visit with the kids, and not be so separated from one another, and like seeing the children playing chess with their elderly grandparents
Yeah.
help keep their brain like spry while they're
Yeah.
having some healthy snacks. Like it's not a piecemeal situation. The solution has got to be systemic. So maybe
Well,
it
and
could.
and from a health IT perspective, we've talked
Mhm.
some about that, right? So we all go in and we see our doctor, and we get 8 minutes or 12 minutes or whatever it is, for primary care. And, some of them will ask, do you have someone to spend time with? So recognition of kind of the loneliness epidemic among the elderly is really important. But what we don't have is that loop from the clinician out to the care environment and the community-based organizations that can completely change the life of somebody, whatever their situation, right? It might be someone who's elderly, it might be someone with dementia, but it might be someone who's experiencing housing insecurity, or who doesn't have a car and can't get to their follow-up appointment for their hip replacement, or whatever it is. We're
Mhm.
missing that loop. And we talked a lot about that in the last administration. And I hope we don't lose sight of that, because it completely affects outcomes. And it also really affects, again, that caregiver environment that can be really hard. And to your point, it builds a little bit more of that community. If a doctor prescribes, I want you to go to the YMCA, and they have, a swimming class for the elderly to keep you active, and they have cooking classes, and they have, you can take this class just to keep your brain fresh and challenged. All of that, if that's a prescription, like, think of that, right? But then you want the closed loop. You want the YMCA then telling the provider, "Hey, it's working, right? It's this
Yeah,
good
I
thing
can't
is
see.
happening for this patient."
Uh-huh.
Exactly. And so we really need to invest in that infrastructure. Where does the data flow? How do we keep that going? How do we make sure that an idea discussed in the exam room makes its way out and translates into the real world? And then, I mean, that's only good for patients. I think that would be fantastic.
Yeah, and the feedback of them not coming back in is not necessarily going to show up on your spreadsheet. So, like any kind of
Exactly.
verbal feedback would be helpful. I have experience with one of these referral systems that, it refers out to the community, but then you never hear back from them.
Right.
And so, yeah, infrastructure and the humans with the buy-in to participate.
Mhm.
It can be done. It can be done. And maybe, if we just keep talking about it and putting it out there, we'll speak it into existence. What do you
Right.
think, Lee?
Yeah, I mean, it has to be pretty local. It's kind of a hyper local thing, right? So North Carolina has a pretty decent structure of community-based organizations that can, on some level, exchange information, but a lot of it is manual. Our pediatrician actually does it. And I had a conversation with them because they use our product, coincidentally. And I said, "Oh, how are you using that? Right? Like, what does this look like for you?" And the woman who runs it is so dedicated, but a lot of it is manual. A lot of it is them, within the EHR, they're asking these questions and it goes to her. So they've set up a workflow, and they're willing to pay for a person which in and of itself is an investment by that pediatric practice. But she then takes that and half the time is manually picking up the phone and saying, hey, I've got, someone who needs a car. What can we do? Or someone whose air conditioning went out and it's causing this problem, right? Or that kind of thing. But a lot of it is very manual. And even in North Carolina, where we do have this investment on some level, she said the majority of the time it is not digital. And so a lot of it is up to the states. What do you invest in? And do you give some of that money to those organizations, to those food banks, to, the housing authorities, so that they can receive it electronically and can loop it back? You can have everything. As you said, you have access to it in your system, but if it isn't received electronically in a way that can be acted on and then closed loop, you're going to lose sight, right? It's kind of a black hole. So we just need to keep investing in that.
Yeah, definitely. I mean, it can't succeed if we don't try, right?
Exactly.
So, well, thank you so much for everything you're trying to push through and what you've been successful at already. And just, I know it's like gonna be a never-ending struggle. So thank you for your consistency over time to make this a priority, even when it wasn't the hot topic that everybody was talking about.
I mean, to me, it's interesting. And I also know, as I said earlier, it matters. I mean, what we do matters. And if we keep our eye on the fact that we really are affecting patients' lives, it's interesting work and it's gratifying. So, hey, I'm happy to do it.
Mm. Well, if someone is listening to this today and feeling inspired by your work and wants to get involved, what's the best way for them to reach you?
Probably LinkedIn. I'm not a huge social media person, but LinkedIn is a great connection force. So absolutely.
And I'll link that in the show notes. And
Thanks.
so, and then the EHR association that you're part of
Mhm.
as well, what's the website for that?
EHRA.org, and EHRA does a fair amount on LinkedIn as well.
Excellent. All right. I'll try and link that in the show notes as well. So if you're listening to this episode and you enjoyed it and learned something, please like it wherever you're listening. Leave me a comment. Let me know what you learned. And if you know of someone else who has a brilliant idea that can make things better and help us make the world a healthier place, feel free to point them in my direction. You can always submit something through nurserosaspeaks.com, or you can find me on lots of social media platforms at Nurse Rosa Speaks. And I'm also on LinkedIn, which will be in the show notes. So make sure you're subscribed if you're listening or watching on YouTube, and I will see you in the next episode.